Hello everyone. So, recently we have started a very interesting series where I read some research article with you all. Today I'll be reading another article in the same series. To be exact, this is the second article which I'm reading with you, and the article comes from International Urogynecological Journal, which is the June issue of the same. So, why this article attracted me? Because it was a very practical topic. So what they're trying to do this in this article, they're comparing two surgical methods. One is our age-old vaginal hysterectomy with repairs for prolapse versus Fothergill's operation for uterovaginal prolapse. So it was very interesting. Now, why it is interesting? If I go back to maybe 3, 4, 5 decades, the first surgery which was accepted and which was started for uterine or uterovaginal prolapse was actually Manchester's repair, which was very common. It started in UK in the place called Manchester. That's where the name came from. And the idea was not for conservation of uterus, no. The idea of promoting this surgery was that in this surgery, when we do not open the peritoneum. So that was the time when we did not have good antibiotics and good anesthetics and good painkillers. So if you open the peritoneum, you have to prevent infection. And if infection happens, you have to treat it because there was not enough available and good antibiotics that time. So this surgery got popularized. It was not at all that women of that time wanted to conserve their uterus. No, it was for the safety of the patient. Then we started having loads of antibiotics in our arena, and then what happened? The anesthesia, the analgesics kept on improving. So the surgery got shifted from Manchester's repair to a more radical kind of approach where everybody started doing vaginal hysterectomy and repairs. The time taken for surgery was not a constraint anymore. The infection was not a constraint anymore. But then the life changed again, took one more turn where everybody started the importance of conserving the uterus in young women, despite the fact that they would have finished their family or completed their family. We are not going to delve into the details of why you should conserve uterus, but all of you know that the era where we are living, even if it is a fibroid, adenomyosis, prolapse, we are talking how can we conserve the uterus, because the women are living a longer lifetime and we don't want to deal with more and more prolapses. That is the urogynecological point of view, but there are many more negative impacts in quality of life and other things related to early removal of uterus. So there is an upsurge of articles related to Fothergills because people want to do it, and after the mesh was banned by FDA, it became more popular method. So there are a lot of studies. If you go into PubMed, you will find a lot of studies recently being published reporting Fothergills as one of the choice of surgery for patients who are having prolapse. So if you want to know the details of what are the steps we do for Fothergill's repair, see our videos. There are some videos which slowly and clearly demonstrate the steps, what we do. But if I have to tell you, every surgery is a surgeon's procedure. Everybody will have nobody does A, B, C, D, similar steps for every surgery. More true it is when we perform vaginal surgeries. So there are little bit modification for every surgeon, and but whatever it is, I have posted long time ago some videos which clearly demonstrate Fothergill surgery, how we do it. So with this information, let's jump on to the article and start reading it together. This article which we are discussing today is from International Urogynecology Journal, which was published in June 2022. The title is Modified Manchester Fothergill Procedure, compared with vaginal hysterectomy with low uterosacral ligament suspension in patients with pelvic organ prolapse. Long-term outcome. So there are two, three things from the title we have to understand what this paper talks about. It looks like that the paper compares two surgical procedures, all in cases of prolapse. The first procedure is uterine conservation, the age-old Manchester or Fothergill operation, and the other one is vaginal hysterectomy with traditional uterosacral ligament suspension, which we also call as low uterosacral ligament suspension. Why? Because now we have another method of high uterosacral ligament suspension. To differentiate it from high, we call it low uterosacral ligament suspension. And what they tried to do, the good thing about this that it is a 10-year, a long-term follow-up where they have followed a patient for at least 10 years. So first, let's read the abstract together. Now, abstract is something, as I always tell you, very important, which tells you whether you really want to delve into the details of that research or you say, no, I'm not interested in this. So, all the important thing about your paper should be captured in the abstract. The unique selling points, I call it. So, this study was a single center and a retrospective study. They tried to compare two groups, one where Manchester Fothergill repair was done, and the other one in which vaginal hysterectomy was done for pelvic organ prolapse. Total number of patients which they recruited actually were 398, but only 160 patients, that is 14% of women, could be caught and they reported the questionnaires. The mean follow-up in this study was around 13 years. And what they found was interesting, that the subjective rate of recurrence was found to be similar in both the groups. So though this study was a single center and a retrospective study, but it raised a very important clinical question as far as today's urogynecological clinical practice is concerned. It talked about long-term follow-up of two totally different. One is uterine conservation procedure and one is vaginal hysterectomy. So much debate is going on about the role of hysterectomy and uterine conservation these days. So this makes it a very interesting clinical question to ask, and the long-term follow-up of patient adds a real flavor because prolapse is something where recurrence rate is very high. So this article is trying to compare the same. I feel it is a very interesting question for all of us to understand in today's scenario. From the introduction part of it, I'm just reading the most important lines what they have mentioned here. They say that although pelvic organ prolapse is common, it is true that there is no consensus on the best surgical treatment. Vaginal hysterectomy with low uterosacral ligament suspension, which we routinely do, is the traditional surgery and it is most widely used surgery to treat apical prolapse. Vaginal hysterectomy, though it is common, but it is associated with longer operating time, more intra and postoperative bleeding, and longer hospital stay. The downside of vaginal hysterectomy is that it is known to weaken the pelvic support system after the intervention or after the surgery has been done and the uterus has been removed. As compared to this, uterus preserving surgery for prolapse has certain benefits. It is less invasive, there are fewer perioperative complications, the duration of surgery is shorter, and the time of hospitalization is also shorter as compared to vaginal hysterectomy. The cost of the procedure is lower and there is good. The total calculated cost of Fothergill surgery is lower as compared to vaginal hysterectomy and repairs. And one more very interesting thing, the recent upsurge in interest for this surgery has come from the evidence which supports that there is good outcome after Fothergill's, as well as the recurrence rate is very low after the surgery later on. And last but not the least, there are several studies which have shown that women have a growing preference towards preserving their uterus after any surgery related to gynecology. So, we have to consider this option in today's world. Now this question may come to your mind that when in introduction part we are already saying that Fothergill's or Manchester repair are very good surgeries, why we have even done this study. So the author understands this and tells it in the later part of introduction that though there are studies which have compared Manchester Fothergill surgery and vaginal hysterectomy, but those studies have shown till now conflicting results. Some studies show lower recurrence rate after Manchester Fothergill repair, while others show that there is similar recurrence rate. But then why we want to do the similar kind of study again? Their argument is that the long-term follow-up, whatever studies have done till now, is not long enough. That is only the maximum follow-up is only up to 6.5 years. So the aim of the study is that the minimal follow-up period was 10 years, which is a decade and a substantial time to say whether recurrence was higher in one group versus the other group. Talking about the important points in material and method section, it was a retrospective study which was conducted in only one hospital in Netherlands. All the patients which were included in the study were operated in the time span between the year 2003 to 2009. In this study, two surgical procedures were compared, the first being Manchester Fothergill repair and the other was vaginal hysterectomy. Vaginal hysterectomy, as happens in our hospitals also, was performed by 3 surgeons, while Manchester operation everybody is not confident of performing, so all Manchester Fothergill repairs were done by only 1 surgeon. Now this is interesting that patients, those were excluded. If you remember the abstract, around 60% of patients had to be excluded from the study. And the reason was because this is the problem of old age. Many women from this group died by the time the study was conducted to ask about their follow-up, or many of them had dementia, so they were not able to fill the questionnaire accurately. For students and early career people, I have this one more advice which I keep on telling. Though we might not be using POPQ everywhere frequently during our clinical practices, but it is very, very important that if you are doing a urogynecology related study and you are planning to publish your research, you must do a POPQ. Otherwise, the chances that the study will get published become very, very thready. So what was the procedure they followed? They first collected the data set of all those patients who were operated in that time during the year 2003 to 2009. And all these patients were sent a letter. This post had 3 components. One was the information about the study, the second was the consent form for their participation in the study, and third was the questionnaire which they were supposed to fill. And it happens many a times when patient did not respond in a time frame of 2 to 3 weeks, all of them were tried to be approached telephonically. Now, as you know, there were 2 surgical procedures which were compared. The authors have provided the details of the procedure and the steps. However, I feel that a pictorial representation of both the surgeries, what they perform, would have created more interest and more understanding among the authors. So, everybody, vaginal hysterectomy, you say, or you call it Manchester's repair, every operation has a little bit here and there modification by the person who is doing it. So, if you want to read the details how this particular group in Netherlands were performing these surgeries, you can go to the paper and read the details for yourself. And what did they look for in the two groups? The primary outcome measure was the recurrence of subjective pelvic organ prolapse in these patients. That means if the patient said themselves that they are having symptoms of prolapse again. The secondary outcome was whether these symptoms require some kind of intervention, which can be in the form of resurgery or physiotherapy or a pessary. If suppose a patient underwent all these three procedures, first it was tried with physiotherapy, then maybe pessary was tried, and ultimately if patient required for relief for her symptoms reoperation, then the most invasive procedure was included in the analysis. That is one interesting thing. All this data, please mind it, they never examined the patient again. All this was subjective questionnaire based analysis. Patient was sent questionnaire and whatever they said, it was believed. So one of the drawbacks of the study was there was no face-to-face interview with the patient, and all the data was derived from the subjective symptoms. Even the examination was not done for those patients. So this is the flow chart which represents how the patients were recruited for final analysis. So initially, in that given span, 398 patients underwent one of those two surgeries. 120 underwent Fothergill's repair, while 278 had vaginal hysterectomy with low uterosacral ligament suspension. Both the procedures were with or without anterior plus minus posterior colporrhaphy. Now, from this cohort of 398 patients, 238 had to be excluded, which is a big number. The reason was that 144 patients declined to participate. 38 patients had already passed away, and 6 patients were not able to fill the questionnaire, most probably because of dementia or other underlying comorbidities. 54 patients, they were not able to get hold of those patients, or they could not be found out actually. So in final analysis, 230 patients were included, in which 53 were in the group of Fothergill's and Manchester's repair, and 107 were those who had undergone a vaginal hysterectomy. Let's move on to the results part and look at the tables and their figures. So this is the comparative table which compares the baseline demographic characteristics of these two groups. P-value was more than 0.05, which was not significant. That means both the groups were more or less comparable with most of the variables except for the three. The first one among those is the age. And I slightly differ from what observation they had. They found that the mean age of patients who underwent vaginal hysterectomy was lower as compared to those who had Fothergill's repair, and the difference was statistically significant. Now, if we look at our practice, usually when we choose our patient for a uterine preserving surgery or for Manchester's repair, we usually choose the patients who are younger in age. And for old age women, we go more for vaginal hysterectomy. And one very important thing there in our mind is that we don't want to miss any underlying malignancy in these women who are older in age. But here, I think they have given the option for every patient. They have not mentioned how they chose the patient for Manchester versus vaginal hysterectomy, but what they noted that the patient who underwent vaginal hysterectomy were younger women in their cohort. The other difference was in posterior compartment defect and anterior colporrhaphy. So this is usually when we choose a patient for Manchester's or Fothergill's repair. One of the important criteria or the thing which is on mind is cervical elongation. If there is a young lady who has more of cervical elongation as compared to anterior and posterior compartment defect, these are the candidates which we prefer to do a Fothergill's repair. However, they found in their women that the posterior compartment defect was, yes, it was more in vaginal hysterectomy group if you look at the percentage, while anterior colporrhaphy was more commonly performed in Manchester repair, even when they compared it with vaginal hysterectomy. These 3 points, which are significant, are a little different from our practice, but we can look at it with the point that it was a retrospective study and they would have believed a lot more in the data which was documented. Maybe these biases can be commented upon with more scientific background in prospective studies. Table 2 is an important table which actually is showing what they followed up after at least minimum 10 years after the surgery was done. And you can see that none of the p-value is significant except the one which says the time of re-intervention. So the time of re-intervention was shorter in cases where the surgery was Fothergill as compared to the one where vaginal hysterectomy was performed. All other things were more or less same without a statistical significant difference in the two. So this is a very important understanding or a take-home message from this long-term follow-up article which was published in a very reputed journal, that as far as recurrence and re-intervention is concerned, mind it that vaginal hysterectomy and Manchester's repair both have almost a similar result. So don't hesitate if next time you are thinking to do a Manchester repair for your patient and she asks the rate of recurrence. More or less, it is the same for both the surgeries. However, you have to understand one thing and you have to explain it to your patient. Look at the first line, that the subjective recurrence, or you can say the rate of recurrence, is very high in both the procedures. And we will be dealing more and more with this number in future because many women are living much more longer as they used to live a decade or two earlier. So you have to be very sure in your mind that what you are doing today, that is not the ultimate. The patient may come back after 10 years, 15 years, 20 years to you for a repeat surgery or symptoms again. This is the figure which is published, which represents the Kaplan-Meier graph. Now, if you don't know what Kaplan-Meier graph is, it is a survival analysis which is used to follow up the survival of the patient. And it can be done not only for the life and death things, but also for what intervention, how good it survived. Like, for example, in simple words, if I have to explain it to you, how good the vaginal hysterectomy results survived, or how good the results of Fothergill Manchester repair survived. So there are two axes. In the x-axis, the time of follow-up is mentioned, and in the y-axis, the requirement till when, how good the surgery survived. That means till when the patient did not have the recurrence has been plotted here. This is how the survival curves or Kaplan-Meier graph demonstrates the survival benefit of any intervention. So the blue line here is the vaginal hysterectomy and red curve is the Manchester Fothergill repair. And you can see from this figure, though almost the curves are parallel in both the groups, however, the vaginal hysterectomy shows a little better results. If you look at the table below, you can see here that the reintervention rate for vaginal hysterectomy in according to this analysis, was 2.27 compared to Manchester Fothergill, which was little higher, 3.58. So the thing is, both did well in the follow-up. However, the reintervention rate was a bit higher in Manchester Fothergill repair as compared to vaginal hysterectomy. Though in vaginal hysterectomy also, remember, it was not zero. Though we think that it is a radical procedure, but it might come again, the patient might come again with a vault prolapse or cystocele, rectocele, even after you have done vaginal hysterectomy repair and vault suspension, mind it. So let's pause now for a while and think in our own mind. Why don't we prefer to do Manchester's or Fothergill repair, which is a uterine conserving surgery for women? The first myth I have already told you, that the recurrence rate of wall prolapse or the symptoms is little bit more with Fothergill's repair, but it is definitely a little less in vaginal hysterectomy too. Don't think that it is the forever kind of surgery. Both surgery, the chance of recurrence in the form of wall prolapse or isolated cystocele, rectocele is there. After understanding them, think about what other things can go wrong. One important thing, that there is always a risk of missing a malignancy. But if you are choosing this procedure for young women, that chance also is nullified. The second thing is that when you are keeping the uterus inside, amputating the cervix and putting a flap there, there is a chance of stenosis there. So these are called the negative effects of Manchester procedure. In this surgery, the authors tell that they required one uterus to be removed after the surgery because the patient developed an endometrial cancer which was detected in the endometrial sampling later on. There were two cases where patient had minimal or moderate pyometra because of restenosis of the canal, but it required only a conservative intervention, just dilatation of cervical canal and drainage of that pus was enough to relieve the symptoms. But whenever we are planning to do that, yes, we have to keep in mind what all can go wrong if we are conserving the uterus in any surgery. Having analyzed the results, let's read together what they write in the discussion. So, at the long term, the subjective recurrence after Manchester Fothergill procedure is similar to vaginal hysterectomy in treatment of pelvic organ prolapse. That's what they finalize. But the recurrence rate was high in both the procedures, which is around 50%, which I'm repeatedly telling you to keep it in mind. So, till now, we don't have the ultimate procedure, surgical procedure for treatment of pelvic organ prolapse. So, a lot of hope. Maybe tomorrow you will devise a procedure with much less recurrence rate. It is indeed a very interesting area to think about, to ponder about such treatment and work on it. So they found, coming back to the article, the authors found that there is no significant difference in the risk of reintervention between the two groups statistically. As I was discussing earlier about the age, in our practice, usually we choose the patients who are younger, have only cervical elongation, more as compared to anterior and posterior compartment defect for Fothergill's repair, while others, the elder women, are chosen for vaginal hysterectomy. But they give a reason for the same. Maybe they gave a choice to all the women, and they are saying that those women who were still menstruating opted for vaginal hysterectomy, maybe for the associated pathology, or they did not want to have menstruation. That's what they have written. Maybe that is one of the factor, but this is little different from what we practice in our hospital. Please feel free to leave a comment below that what do you think about this age variation and how you do it in your practice. One more line from the discussion, I want to read it out loud for you all. They say that when we consider only the reoperation rate for recurrence of POP, we found a reoperation rate of 23% for Manchester Fothergill group and 12% for the patient who underwent vaginal hysterectomy. And it was after mean follow-up 13 years. This was not significant statistically in their analysis, but they agree to the point that it may be clinically relevant when we are explaining about it to our patients. Whenever you write and publish a paper, it is very important that you recognize your limitations too. So the authors have mentioned that this study too had a few limitations. The first one, as we have already discussed, that it was a retrospective study, so the data was not accurate, or we had to depend on whatever the documentation was done 10-15 years ago. Second thing, no examination or face-to-face talk was done with the patient. It was just a solely questionnaire-based study. Third one, yes. So we have discussed this also, that Manchester Fothergill procedure was performed only by one surgeon, while 3 surgeons performed vaginal hysterectomy. A more variety would have been better to compare the results. Finally, the loss of follow-up was quite high, around up to 60%, because of the long follow-up and the high age of study population, which is easily explainable. The strength of the study lies on its aim that it was a long-term follow-up where they tried to compare the results after the surgery was done 10 years ago. In conclusion, the authors say that there was no significant difference in subjective recurrence rates between Manchester procedure and vaginal hysterectomy with low uterosacral ligament suspension in their cohort. Thus, shared decision making and careful deliberation of pros and cons of all treatment options are needed in choosing the type of treatment for pelvic organ prolapse. Correct. And what's my take home message after reading this article thoroughly is that let's not get scared of Manchester Fothergill repair, and let's stop thinking that vaginal hysterectomy and repairs is the ultimate treatment. Both have almost similar rates of recurrence. So let's develop the skills and add Fothergill surgery also in our armamentarium of surgical management of pelvic organ prolapse. I hope you enjoyed this paper. Thank you.